Hello, I'm Dr. YouTube. I regularly upload medical educational videos. In today's episode, I will talk all about diabetes mellitus, the pathology, the diagnosis, the complications, and treatment, hopefully in less than 10 minutes. To understand diabetes mellitus, I think one must first understand what is actually wrong. Now, it all lies in insulin. In type 1, you're insulin deficient. It's commonly associated as an autoimmune disorder where the body attacks itself, attacks the pancreas. In type 2, it's insulin resistant. So type 1 is insulin deficient, type 2 is insulin resistance. Now the pancreas consists of 4 types of cells, endocrine cells. Alpha, beta, delta, and pancreatic polypeptide ones. About 70% of the pancreas is made up of insulin secreting ones, the beta cells. So to develop insulin, so type 1 diabetes, which is, remember, insulin deficient, you must lose about 70% of your islet cells in order for that to occur. I think it may also be worthwhile just to try and recapping the different secretory products of the pancreas. Alpha cells secrete glucagon, those raise the blood sugar. Beta cells secrete insulin, lowers blood sugar. Delta cells secrete somatostatin. I remember statin, so static, so basically everything stays the same. Inhibits insulin and inhibits glucagon secretion. Pancreatic polypeptide is a bit of a special thing, inhibits pancreatic enzyme secretion. Okay. But anyways, the one you need to know is insulin, secreted by beta cells, and makes up 70% of the pancreas. So as I said before, in type 1 diabetes, it's an autoimmune disorder, so body attacks itself. Now there tends to be about at least 70% positive in these type 1 patients have a positive antibody test, so Islet Cell Antibody or GAD antibody or Zinc antibody levels are positive. If you look under histology, the body attacks itself, so you get a lymphocytic infiltration as this autoimmune disorder. The treatment is insulin. Okay. Now, if it becomes really, really bad, where I will mention later, insulin affects multi-organs, including the kidneys, then perhaps a pancreas and a kidney transplant may need to be considered. So that's type 1 diabetes. How about type 2 diabetes? You have insulin resistance. So the body's producing insulin, but it's not the effect of insulin is not working. So these people, they tend to be a bit more obese. However, the complications, especially of diabetic ketoacidosis, is relatively rare. We briefly touched on the pathophysiology. Let's look at it a bit more. What happens when you have high sugar level? Well, sugar gets into the cells, so into the eyes, and the lens especially, causing cataract. It can affect the kidneys, so remember you have your basement membrane. Basement membrane actually thickens in people with diabetes, but it's more permeable, so it allows things to leak out, like the albumin. Initial stages is called Microalbuminuria, but as it progresses, it can cause proteinuria. If you can recall, the kidney is a special, very important organ. It produces EPO, erythropoetin, so less of it is made. You get anemia. You get less vitamin D production, so some people need to take vitamin D as a result. It can also affect, aside from the lens itself, you can get blood vessel growth. And the reason for that is because you have what we'll call age formation, advanced glycation end product formation. And this increases collagen production in the eyes and everything thickens, okay, including the blood vessels. So you get ischemia of the eyes. When you get ischemia of the eyes, VEGF, vascular growth factor is made, and this increases production of very fragile blood vessels. So you're more prone to bleeding in the eyes. You also get hypertension, and the reason for that is if you imagine you're peeing all that sugar, okay, all that water gets drawn into your pee. You get very dehydrated. You get that sympathetic surge result. You get your renin aldosterone production, and that becomes a vicious cycle. Dehydration, renin aldosterone ratio increases, and becomes a vicious cycle. You're peeing out all that sugar, so therefore you get the polys. So polydipsia, basically drinking a lot of water, polyuria, peeing a lot, and polyphagia, frequently eating. Now what happens to the sort of extreme spectrum of diabetes? So diabetic ketoacidosis, which as I said before, is more common in type 1 diabetes mellitus. You're insulin deficient. Remember, type 1, insulin deficient, type 2, insulin resistance. You're insulin deficient, so insulin is a anabolic hormone, okay? So if you're deficient in insulin, everything breaks down. Protein, okay? Protein catabolism. Your fat breaks down, okay? And as a result, you get free fatty acid formation as a result of fat breakdown, okay? And also, because you're peeing out all that sugar, as I said before, you get that osmotic diuresis. You're peeing out all that sugar that draws in everything, including sodium, potassium. You become very dehydrated. Dehydration. You get that free plasma fatty acid from fat breakdown, increasing your acidosis, and that could eventually lead to death. So that's insulin deficiency in a nutshell. The treatment to correct the insulin deficiency, especially in type 1, is insulin. So, we talked about pathology. We talked about what can go wrong in insulin deficiency. Let's briefly touch on the diagnosis. So, as I said before, polyuria, polydipsia, polyphagia. So the diagnosis is basically hyperglycemia, so diagnosis of diabetes. Fasting glucose, though I remember 7 and 11, like the convenience store. If you're symptomatic, then you need symptoms plus an abnormal blood test. For example, fasting glucose more than 7, or oral glucose tolerance more than 11. So to perform oral glucose tolerance test, you basically check an overnight fast, check the blood glucose first thing in the morning, give them 75 grams of glucose, wait 2 hours, and then check the glucose again. If it's more than 11 and they're symptomatic, then they have diabetes mellitus. You can also check their HbA1c, so it's above 6.5, in other words, 48%. 6.5%, in other words, 6.5% is equivalent to 48, and that is diabetes mellitus. So asymptomatic is, basically, if they're asymptomatic, you must have abnormal blood test. If they're symptomatic, then you need sorry, let's just rewind. So if you are asymptomatic, then you need 2 abnormal lab values. If they're symptomatic, you only need 1 abnormal lab value. For example, fasting glucose, for example. Okay, now complications we briefly touched on. So eyes. So remember, you can get cataracts because of all that sorbitol. The glucose converts into sorbitol on the eyes, draws up all that, So therefore your lens becomes cloudy, you get cataracts. We talked about VEGF formation, VEGF formation. So you get retinopathy, different stages of diabetic retinopathy. You get background, preproliferative, proliferative, and maculopathy. So dot and blot hemorrhage, cotton wool spots. It's basically areas of infarct in the eyes. Proliferative is due to the ischemia, and as a result causing neovascularization and maculopathy. Nephropathy, as I mentioned before, you're peeing, although your basement membrane is thickened, you're peeing out all the protein, and that is bad. So we talked about insulin as a first-line management for type 1 diabetes mellitus. And for type 2, you get insulin resistance. So how can you increase the insulin sensitivity? Sometimes you can give them metformin, okay? Sometimes you also want them to secrete insulin, and sulfonylurea is another method. How it does that, it's ATP-sensitive potassium channel. It closes it, so therefore it increases insulin release. And there you have it, guys. Diabetes mellitus in a nutshell. Let's quickly recap. Type 1 diabetes is insulin deficiency. Type 2 is insulin resistance. Pathophysiology is you get glucose going into cells, so in the eyes, causing cataracts. Kidneys, you get leaky basement membrane, although it's a bit thickened, peeing out all the protein. In the eyes, you get new vessel formation due to ischemia. You also get hypertension due to all that hyperosmolality and osmotic diuresis. You also get acidosis, which can happen especially in type 1 diabetes due to insulin deficiency with fat breakdown, and that is bad. Complication of that includes diabetic ketoacidosis. The diagnosis, if you're asymptomatic, you need 2 abnormal lab values, so 7 as a fasting or 11 as a glucose tolerance test or HbA1c. If you're symptomatic, you only need 1 abnormal blood test. Polyuria, okay, Polydipsia, and Polyphagia. The treatment for type 1 is because it's insulin deficiency, you give them insulin. If it's type 2, which is insulin resistance, you give them things to sensitize the insulin, such as metformin, and other adjuncts, such as insulin, sulfonylurea, and so forth. I think that's it. So I hope you've enjoyed this video. If you do, please give it a thumbs up, like, and subscribe. Take care, and let's look after our pancreas, our beta cells.